So how effective is our optimal bone health program at reversing osteoporosis? This is a big question. And it's a question that we get all the time because really the way I see it, we're leading the charge from a worldwide perspective now because of this channel, trying to educate people that osteoporosis is reversible and that a natural solution can work for the vast majority of people. So the big question is from viewers, from our patients, from our Osteo Collective members, and from my colleague doctors, how effective is a natural approach at reversing osteoporosis? Because we all hear anecdotal stories, and I've shared case presentations on this channel that would demonstrate that not only can you reverse osteoporosis, you can do it in a big way in a relatively short period of time, like 12 months. But the question is if you take a population at large, and you have them go through this lifestyle modification, what will happen to the vast majority of them? What is the chance that of this group, some of them are not going to have osteoporosis at the end of 12 months? What's going to happen to their bone mineral density on average? What's going to happen to their bone turnover markers on average? That is a very difficult question to answer. However, we started collecting data a little over a year ago to help us to show that what we're doing is effective. I'm going to talk about that data. I'm going to talk about, too, what it means to reverse osteoporosis. So how effective is our optimal bone health program? This is a really important question because the way I see it, we are leading the charge on a worldwide scale to educate people that osteoporosis is reversible and preventable in the vast majority of people. But what does the evidence actually say? Like, what actually would happen if we were to take our program, put it in front of 1 million people with osteoporosis? What would happen to that 1 million people? Would they see, on average, an improvement of bone mineral density? Would they see improvement in bone turnover markers? How many of them would no longer have osteoporosis after 12 months? You see, if we could collect that kind of data, then we would be able to say what happens if you do this particular natural intervention for this particular age group, right? What about women 60 to 70 years old who are post-menopause, not on hormone replacement therapy? Like, you could start asking these very specific questions. Now, to be fair, we don't have that data, but what we do have is the data that we've started collecting in our practice a little over a year ago. Now, just for context, so we started this practice about 4 years ago. We niched down into osteoporosis exclusively because we really found our mission and really wanted to serve the population. So we started really defining what we do very clearly about 3 years ago. It took us a while to get the program up and running the way that it is now. I'm going to talk a little bit more about that. But we started collecting data a little over a year ago. So we have some early data. And I'm going to talk about challenges with collecting data in the real world, not in an academic center. But in this video, what I want to do is I want to define what reversal really means. I want to define what success really is. I want to define how we set our goals for our patients. And then I am going to share the actual numbers from our first data set. So for me, this is a really big deal because we are absolutely committed to building the best program for reversing bone loss. We're committed to putting all the tools in one place so that if somebody's struggling to do it on their own, we've got you, we've got the thing to do. So for me, this is a really big deal because if we can show that certain things are more powerful than others, then we can help people to pick and choose of the things that are available to them. And this is going to be super powerful in our mission worldwide, again, to help show people the path forward. So let's talk about some definitions here. So what does it mean to reverse osteoporosis? Because we get this question again frequently. How many people reverse how successful are you in reversing osteoporosis? Well, for me, because the definition of osteoporosis is not very good to begin with, I actually don't really like the definition of reversing osteoporosis either, but it's kind of like reversing diabetes where you have a very clear definition. So if you no longer meet that clear definition, then you no longer have the disease by definition, right? So if osteoporosis by the World Health Organization and the NBOF, if that definition as defined by them is having a T-score on DEXA less than negative 2.5 in any site, then reversing osteoporosis means just improving your bone health to the point where your T-score is no longer less than negative 2.5. Great. Now, for me, that's actually not a great goal because let's say your T-score was negative 2.5 or negative 2.6, and now it's negative 2.4. Like, can you just wash your hands of it and walk away? No, of course not. So reversing osteoporosis is a good goal, but honestly, it's not the best goal, depending on your starting point for sure. So then how would I define success? So for my patients, what I say is, let's pick a really good goal. We're going to talk about goal setting. Let's pick a good goal, but let's include more than just T-score, right? We look at T-score, but there are so many more important things than T-score, because T-score just tells you, again, density. So yes, I want to know that your T-score is going up, and that's fine. I want to know about, if you have access to REMS, your fragility score, or if you have access to TBS, is that improving? Although not a great marker from my perspective. I want to know about your bone turnover markers. Is your P1 and P going up? Is your CTX coming down? What does your ratio look like? I want to look at your biomarkers for health span otherwise, right? Like if we're improving your bone health, but your cardiovascular system is falling apart, we're not really doing you any good. Same thing if you're doing something that is going to provoke dementia, going to provoke Alzheimer's, right? Then we're not doing you any good. So we need to make sure that the biomarkers for health span are improving. And I also like to point out to people, because everybody wants to reverse osteoporosis in my world, and that's great. But remember that actually not losing bone is still a win. So if you're frustrated at yourself because you are doing all this work and your DEXA looks the same, that's a good thing. So not losing bone is still a win, although for many of us, of course, we want to improve our bone mineral density, we want to improve our bone strength and reduce our fracture risk, and that is really a good goal. So let's talk about goal setting. So one of the most important things when it comes to goal setting is to understand your starting point. So I was listening to a call between one of my providers and a patient, and they were just grilling my provider about how many people reverse osteoporosis, and just really wanted to know how many people reverse osteoporosis. And so, I think it's interesting to think that somebody would be so compelled and driven by that answer, understanding though that if someone has a starting point of, like, say, a T-score of -5, like they have terrible bone density, they could reverse osteoporosis, but they're not going to do it in 12 months, right? They're probably not going to do it in 5 years. So if you have a really low starting point, then you really should give yourself some grace and understand that a good goal, a good path forward is to go from -5, let's increase it 2%, 4%, 6%, right? So let's move. So now you're -4 or whatever, 6. So we need to set realistic goals and understand that reversing osteoporosis in 12 months is not a realistic goal for many, many people. And then also understand your limitations. So let's talk about goal setting. So a lot of people want to reverse osteoporosis, and that's great, except that you need to understand your starting point. So if someone has a T-score, let's say of -5, and they're going to work with us for 12 months, are they going to reverse their osteoporosis in 12 months? Not a chance. We need to set realistic goals. And we're going to talk about some actual goal setting strategies. But we need to understand our starting point. What is our bone density? What's our fragility score, if we have access to that, or TBS? And then what are our limitations? Can we exercise hard? Can we do heavy resistance training? Do we have medical comorbidities? Are we under a lot of stress, social stress, et cetera? Can we use HRT? Is it an option? Are you contraindicated to doing that? So once you have sort of an understanding of the big picture of what your limitations are, because we all have them, it's not a bad thing. We just need to understand them. So then I like to use this SMART framework, which you probably all know, but just in case you don't, the SMART framework for goal setting is be specific, be measurable, be achievable, be relevant, and be time-bound, right? So it's an acronym, be SMART. So we want to set these goals very, very intentionally. Okay, so let's just set a goal as if you're my patient, okay? So let's just say you're 62 years old, you have osteoporosis, your T-score is -3.5, you haven't had any fractures, you're not on HRT, but you could be. You've got some work to do from a nutrition perspective, gut health, et cetera, right? You probably haven't been doing a lot of exercise, but you're okay with it. You've got some arthritis, you've got some aches, some pains, but you can actually do some weightlifting. It's a really good starting point. But are you going to reverse your osteoporosis in 12 months? Probably not. To go from -3.5 to over -2.5, that would be a huge leap, and in 12 months is unrealistic, probably. But we can definitely get you going in the right direction. So let's set a specific goal, and it doesn't even have to be a T-score goal. Actually, I would prefer it not be. But let's just, for sake of argument, let's just set a goal. Let's say I want to go from -3.5 to -3. See this happen all the time. So that's measurable. So that's the M. Is it achievable? Yes. Is it relevant? Yes. I'm going to do it in 12 months. Now it's time-bound. All right, that's an easy goal. I would suggest you set some goals in addition to T-score goals, but that's a great goal, right? So let's just start with that. So I'm going to get to our numbers, and I'm going to actually compare them to some drug studies too, because I think it'll be a fun way to do this. But I'm going to get to our numbers. But before I do, if you're struggling to put together your own bone health program, please consider coming to our masterclass. It's totally free. You get to hear me talk about myths, misconceptions of bone health as we see them in our patients and Osteo Collective members. And we'll save about 20 minutes for Q&A. So if you are, again, looking for more answers, you want to have the ability to ask questions, look for the link down here in the description in YouTube, or go to our website, optimalhumanhealth.com, and you can sign up for our masterclass. Okay, so let's talk about these numbers. All right. But first, I want to preface this by talking about how hard it is to collect data in the real world. We're not an academic center. In fact, we are, by all measures, a tiny clinical practice. Our systems are not designed for clinical research. They're designed for clinical use. They're regular electronic medical records so that we can keep track of our patients and what we're telling them. It is hard to collect data. It takes a lot of time and effort. And we hired somebody to start pulling data out of our electronic medical records so that we could start to analyze this. I feel that we're obligated to report our success because truly we are a one-of-a-kind practice. We're the only practice I know of that focuses exclusively on this problem. But the challenge with bone health data is that imaging modalities are slow to change, particularly DEXA. DEXA has a wide range of variability. So we know you've heard probably on this channel, you heard Dr. Kim Zambito talk about a plus or minus of 4, maybe even 6% or more variability from DEXA. So if we're saying that a 5% improvement is a huge win, but that's within the margin of error of the study, this is a problem, right? We may have seen a 5% improvement, but the DEXA looks worse. So, these are frustrating things that are just incumbent upon all of us to try to look past. But fortunately, that's not the case. We do see some improvement. I'll show you that. Now, our program is designed to be 12 months long, and we have played with other time lengths. I would love to have people in our world for 5 years or 3 years or whatever, but it's not a realistic thing to actually ask somebody to do. So we go in 12-month intervals, and some of our patients do stay for longer, but for the most part, we have data for the first 12 months. And again, we only started collecting data a little over 12 months ago, so we only have this sort of first set. We've now served over 600 patients. We initially didn't do bone turnover markers at the end of the program because people that continued on would get them then, and not everybody did that. So now we do that, but we didn't initially. So what I'm going to report on is 6-month improvement of bone turnover markers. In the future, we'll have 12-month improvement of bone turnover markers. We also didn't used to push people to do DEXAs at the end of their program. And that's because when we educate people that T-score is not the most important thing, it turns out they don't care so much about their T-score. So they don't necessarily go get a new DEXA because they're looking at other markers. We also have people that will switch from DEXA to REMS, even though we say you have to compare apples to apples. They'll say, well, I had a DEXA. I don't want to do DEXA anymore. I only want to do REMS. So I'm just going to get a REMS. I don't want to pay for a DEXA. But then I can't compare their DEXA to their REMS. That wouldn't be fair. So again, that could be an issue. Early on in our practice, when we initially built this program, we also didn't have all the tools that we have now. So we didn't even have an exercise program built in. And then when we did build an exercise program in, it was very, very conservative because I was concerned about what we could actually do through telehealth in a safe way. We have continued to progress this. So we're actually recording this weekend version 4 for us of an exercise program for progressive resistance training through a telehealth platform with one-on-one assistance, but to the point where we can do some pretty heavy resistance training. But early on, we were doing, mostly not heavy resistance training. And it was a lot of yoga, floor Pilates, that kind of stuff. We knew that wasn't what everybody needed, but it's something that everybody could do. And then we would have them do additional things. So this is that group, right? So we didn't even have the tools that we have now. We also didn't have the understanding of hormone replacement that we do now, right? I started out, I was trained to use Biest, which you've probably heard me talk about isn't the best tool for bone health. So we were not using enough estradiol out of the gate, and now we're using more. Now we're using FSH and other biomarkers to help us determine, if we are truly optimizing HRT. So again, this group didn't have the best HRT out of the gate. Additionally, we still start low and go slow. So sometimes people, by the time they get to 12 months, they're just now getting their hormones optimized. And sometimes they still have room to grow. And that's why they'll transition from OHH into pemobioidentical. It's not responsible to take somebody who hasn't had hormones in 15 or 20 years and give them optimized levels of hormone out of the gate. They're not going to feel good. It takes time in order to get up to speed, but what we're looking at is the improvement at between the 6 and 12 month mark. Okay, so here's the actual numbers you've been waiting for. So when we look at bone turnover markers at the 6 month mark, again, this isn't the 12 month mark, this is the 6 month mark. We see that 80%, almost 80%, just under 80% of patients from the beginning to the middle of the program have seen an improvement in their bone turnover marker from a ratio perspective. And that's great. I wish it were 100%. But when you consider how the program rolls, it takes about a month or potentially even 2 months to get onboarded, get your labs, meet with your dietitian, meet with your provider, come up with a plan, get all the things that you're going to do, and then start doing them. You could be 2 months in. Sometimes it gets delayed for whatever reason. People don't start, supplements are not tolerated or whatever. So some people get a really slow start. So then by the time we repeat labs at the 6 month mark, because we're actually doing the labs at the 4.5 month mark, you can see how the initial component of the program could get pretty short. So we're always adjusting this. But just to understand that 6 months isn't actually 6 months of therapy, it's 6 months into a 12-month program. It might take 2 months to get up to speed, potentially even longer for some people. So I look forward to seeing the 12-month data because I think at 12 months, we're going to see a massive improvement. Probably, I don't want to put a number on it, but I think higher than 80% of people are going to see improvement in bone turnover markers from a ratio perspective by the 12-month mark. So I tried to pull some data on what happens in drug studies. And I pulled this one study because it uses CTX, for example. And this is what CTX is used for in drug studies. But this is the CARD extension trial. And this is using bisphosphonates after Prolia. Now, what was interesting here is that I wanted to show that even in the drug trials, you don't see consistent improvement in bone turnover markers, or you don't see them happen that quickly. And so what you can see in this drug trial is that, yes, they were measuring CTX. However, the average improved. But if you look at the curve, not everybody improves out of the gate. But something that is consistently reducing CTX, like a bisphosphonate, you can actually see that it takes a while for it to change. And then once it does change, it doesn't change in everybody right away. So even in a drug trial, these can take time. So again, our results are comparable. I think that they're actually probably pretty darn good for a natural approach. We'll talk more about natural versus pharmaceutical in a minute. Okay, so imaging. This is what everybody wants to know. So we saw an improvement in DEXA to DEXA or REMS to REMS in 61% of our patients within that 12-month mark. Now, remember that for a lot of people, it takes more than 12 months to see an improvement in DEXA. So that doesn't mean that they're not getting better, just means that they're not seeing it yet. But we also have a lot of issues with imaging in this group because we don't force people to get imaging. Some people don't want to pay for it. Their insurance is going to pay for it. They're going to wait for longer. We don't have long-term follow-up. So this is a big challenge that we are grappling with, is how to encourage people to get that repeat DEXA reported to us so that we can report it to you. So I don't mind that this number is only 61% because, again, their program, they haven't been doing intervention for 12 months. They've been doing it probably for 10 months, for some people even less than that. And even then, even if it were 12 months and you were doing all the natural things, these things take longer to actually work. And it takes a while to get hormone replacement therapy up and running. So you're not just going to start doing heel drops and lifting dumbbells and you're going to see improvement in DEXA and by doing that alone. So this takes time to get ramped up. Now, I think this is interesting if you compare this to this study. So this is our second study here. This is one of the bisphosphonate trials that led to the approval of the drug. And what's interesting, if you look at the curve of bone mineral density, it really took 3 years to see that most people were improving. So in this one in particular, this was 1,000 people, and it took 3 years for them to hit 96% of people improving bone mineral density. So I'd love to see what our patients can do in 3 years. I think we would be pretty darn close to that, if not higher, if I had 3 years to work with people, a full 3 years, and I had their commitment to do it. The other thing I wanted to talk about here too is that when you compare drug therapy to natural therapy, one of the many reasons why doctors lean on drugs is because it's easier to get somebody to take a pill or do a surgery than it is to change their lifestyle. This is part of the challenge of lifestyle medicine, which is when somebody comes to me, I'm asking them to change the way they eat, the way they shop, the way they spend money, the way they spend their time. And that's hard. Lifestyle is hard to change and it takes work. That's why we built the team that we built. A pill, relatively easy to take, assuming you can remember to do it. And so we are also faced with the reality that a lifestyle program is going to be less effective than a drug almost all the time in the general population. Now, my patients are not the general population. They are committed. They are working hard. The vast majority of them are doing the work. But if we look at those that aren't succeeding the way that we would expect them to, go back and look in their chart, we see that many of them were not particularly engaged in the program. So in our program, you meet with your dietitian regularly. We have group health coaching programs. We now have an exercise component that is individualized. For the people that are engaging in the program, they see better success. For the people that are on HRT, they see better success. For the people that aren't engaged, aren't able to use HRT, don't appear to be doing the work, it's no surprise that they don't see the results. And there's lots of reasons why that could be. It's not that they're bad people or they're lazy or they're unwilling to change. Life happens. So, when you have a 12-month period of time and you commit to doing something in 12 months, what happens when you're in Asheville and a hurricane blows through and your house gets swept away? What happens when something, close to you happens to a family member? What happens when life happens? So we can't just say that, oh, they didn't do the work. Well, something happened, I'm sure they meant to do. I'm sure they were well-meaning in their intentions. But sometimes people are unwilling to make change or sometimes something gets in their way. So again, lifestyle is so much harder than drug therapy. And then the fun number is how many people actually reversed osteoporosis. That number actually turned out to be a little over 50%. I'm actually surprised at that number because we have some really low starting points. But just statistically, the people that had repeat DEXAs, that's just how it worked out. So 50% of the patients that were in that initial cohort actually reversed osteoporosis. I'm actually pretty happy about that. That 61% number, I'd like to see it much higher, and I think we will see it much higher once we have enough time after people have been doing the intervention. The big takeaway here for me is that we can demonstrate through this that osteoporosis is reversible in most people, even our patient population. The biggest factors that we see are the ability and willingness to optimize your diet, the ability and willingness to optimize exercise, to do impact or simulated impact or some kind of modality, the absence of comorbidities. What I mean by that is we have some very well-meaning patients that have some very terrible medical problems that really limit their ability to do the things that they want to do. So that just gets in the way. Doesn't mean you can't be successful. It's just slower. The ability to do HRT is huge. So the ability or the willingness to undergo hormone replacement therapy for a woman post-menopause, it's not required to be successful, but it will absolutely amplify whatever approach is working. So if you can go on HRT, that's a big tool. We continually show that over and over again in our patients. Now, what about the ugly things? Fractures. So I'm going to be totally honest here. We don't do a great job of documenting fractures. However, if somebody fractures, I hear about it. So I would love to say that nobody has fractured while they've been a patient of ours, but that would be silly, right? We have 600 plus patients with osteoporosis that we've worked with that are out there living their life, learning how to do resistance training, walking their dogs on ice through the winter, whatever. Fractures are going to happen. I will say though, that if I look at the fractures that I can remember, most of them have been things that people would have likely fractured anyway. So even if they are classified as a fragility fracture, technically because they have osteoporosis, I can think of off the top of my head, nasty car accident, falling in a way that was just wild, resulting in a hip fracture. We have had some things like femoral neck stress fractures, acetabular stress fractures, some vertebral fractures that have happened from even things like osteogenic loading. These things happen, and I'm not saying it's okay or that I accept this for my patients, but if you compare a natural approach like ours to a drug study. And I just had somebody tell me this, and this drives me nuts. So we had somebody who was interested in working with us, and she said, well, can you guarantee that I'm not going to fracture? And we said, of course not. Can't guarantee anything. So she said, well, then I'm just going to go take Prolia because the doctor tells me it'll prevent fracture. That's not true. If you look at the drug trials, the placebo group has fractures. The drug group has fractures. In fact, the difference between the placebo group and the drug group is surprisingly small. It's a big enough difference to meet statistical significance, and you can come up with a relative risk that sounds nice in a paper. But the actual difference, the absolute risk difference, is usually really small. So I would love to have enough data to say that 600 people go through our program, 600 people do nothing. Is there going to be a difference in fractures? I don't know. I think that we probably would see less fractures because people are doing the things that are proactive to improve their bone. But as you get older, as things happen from a medical perspective, if you already have osteoporosis, fractures are just one of the things that we need to try to avoid. That's why we're here. So I think the biggest takeaway here is that when it comes to a natural approach, yes, we hear anecdotal stories all the time. This influencer reversed their osteoporosis with, whatever. This supplement company says that, hey, look, these 5 people who left reviews reversed osteoporosis. That's all fine. But what we really want to know is, in a big group of people who are going through a natural approach, a comprehensive approach, what's the likelihood that they're going to see an improvement in bone mineral density? What's the likelihood that they're going to see improvement in bone turnover markers? What's the likelihood that they're going to reverse osteoporosis? I think what's really cool is that our numbers, even though they are, incomplete at best, but our numbers are actually comparable. I can actually look at a drug study and say, yeah, okay, this is comparable to this. This is comparable to this, and the more data we have, the better we'll be able to do this. But the biggest difference here is that our approach can be done indefinitely without the risk of side effects like a typical femur fracture or osteonecrosis of the jaw. We're improving bone health through the lens of healthspan. We make people not only feel better just about their bones, we make them feel better in general. We make them feel stronger. They are stronger. They have more energy. They are thinking better. They have improved cardiovascular risk based on biomarkers. They have hormone optimization. They have improved libido, desire, sexual performance, better sleep, and on and on and on and on and on. Okay, so do I love this data? Not really. It needs to be better. In fact, I think it is better, actually. We just don't have the numbers to actually show it. The biggest challenge I see is that it's truly an incomplete data set. We need to fill in the holes. We need to do a better job of capturing data, and we are. Future data will be better. I'll report them here. Just as of the time of this recording, we're switching to a new EMR that'll help. We are now providing bone turnover markers for free at the end of the program so that we can demonstrate the improvement that they've had. We're now pushing for repeat imaging. We actually have team members out there calling people saying, hey, have you gotten this test? What are the results? Can I put this in your chart so that we can analyze it? So we're trying to do that long-term follow-up. It's hard and it's expensive, but I think it's important that we demonstrate to the world that osteoporosis is both preventable and reversible in the vast majority of people without drugs. Ultimately, you get to choose. And this is what I told this person who said, hey, I want to go on Prolia so that I won't fracture. I said, look, you get to choose. The drug route has risks, it has a limited time span, and there's really no long-term plan. But the natural approach also has risks. It has really an unlimited time span, at least for your lifespan. The numbers are getting more comparable with drug numbers, and you don't have to choose one or the other. You oftentimes can do both. What I mean by that is that we see a lot of people who are scared because they're on bone health drugs. They're on Prolia, they're on bisphosphonates. They're looking for something to do, but they feel like they've almost committed to being in this camp of drugs and that's all they can do. But that's not true. All the drugs work better if you have a comprehensive lifestyle program. All the drugs work better if you are eating the right diet, you're nailing your exercise, you're doing all the things. The drugs actually do better. True for the anti-resorptive drugs, true for the anabolic drugs. So my recommendation is if you're on a drug and you feel like you're trapped to be on that drug, it's possible to get off these drugs, but you have to have a comprehensive program in place. So before you go jump ship, make sure you're doing all the right things. Talk to your doctor before you stop any drug, of course, but just know that we see this. We see this collaboration between the two happen on a regular basis, and it can really help to amplify the results of both. All right, so that's it. Remember that a diagnosis of osteoporosis isn't the end. Deciding to be on a drug is okay, but deciding to reverse your osteoporosis is the beginning of a beautiful journey. I'll see you in the next video.